Well, welcome along to the Coaching Corner this June the 3rd at the beginning of winter in Australia, and Melbourne is in yet another lockdown. But anyway, it gives us lots of time to get things like this ready tonight. I do want to say and give a nod to our sponsors for the evening. Philips Healthcare has very proudly sponsored tonight's presentation, and we do thank them for their support, particularly in these turbulent times during lockdown. So I do want to acknowledge their support. I'm going to just remind everyone that the webinar tonight is recorded. We do edit out the beginning chat and the end chat, but if there are questions that you wanted to ask offline, just let me know and I'll let you know when the recording will end so that we can talk about those things more freely, if you like, after the recording's done. But in the meantime, if you've got any questions, feel free to just shout out while I'm going along, because I find it a bit tricky watching the messages and everything along the way. So just give a shout out while we're going along. Tonight's topic is going to be ultrasound assessment of renal colic. So patients presenting to the emergency department with flank pain and hematuria will inevitably undergo some sort of imaging as part of the workup for kidney stones, so that we can determine the location of the stone and therefore figure out, how we're going to treat them or what might be the possible other consequences of this stone. Often the location of the stone can be anticipated based on your physical exam. Now, imaging patients with kidney stones facilitates their management because we can establish the size and the location of the stones. And so if we choose the right modality, we can get that process underway much quicker. And choosing that right modality involves many factors, which does include the clinical setting and the availability of various different imaging modalities. So if it's 3 o'clock in the morning and you don't have access to the CT, it's handy to have an ultrasound machine in your pocket. Often the patient's body habitus might influence what imaging modality we choose, because as we know, those patients with larger BMIs are not the most ultrasound friendly, should we say, to image. If you're looking for a tiny little calculus that might only be 5 millimeters or 6 millimeters, it's very hard to see some of those on ultrasound, even in ideal patients. So an increased body habitus is a contraindication, if you like, for ultrasound imaging. Other factors that might come into play is the cost and the patient's tolerance for ionizing radiation. Have they had lots of tests? Are they pregnant at the moment? That might mean you make a different decision. So stone formation can be quite complex, and it can depend on the composition of the stone as to how visible they can be on ultrasound. As they grow in the renal calyces, they're often asymptomatic, and it's only once they pass into the ureter and obstruct the flow of urine that it causes upstream dilatation and then the resulting sort of colicky type pain, and that's because you get that increasing ureteral peristalsis. Classically, the stone obstructs near that uretopelvic junction where the renal pelvis narrows to the caliber of the ureter. And that generally causes pain that can radiate to the flank. But there are two additional points of narrowing where it crosses the iliac vessels up here and down here at the uretovesical junction. Obstruction at those iliac vessels might cause pain that radiates to the groin or lower abdomen, and stones that lodge in the ureterovesical junction cause pain to radiate to the scrotum and labia. But that can often also, increase urinary frequency and other symptoms because that stone's now irritating the bladder. And as those stones pass, they can cause abrasions, which then results in the hematuria that you can see. So, having a good clinical exam is great for sort of figuring out where you think things might be happening. The initial imaging is the first step in disease management. And so identifying that there is a stone and its potential sequelae, you can assess the size of that stone, its location, and it helps you to figure out what the risk is regarding the passage of stone and whether it may or may not need surgical intervention. If the stone passes, if the stone doesn't pass, but it causes asymptomatic obstruction, then it can lead to a potential loss of renal function and even kidney failure. So it's really important to find these things when they're present. If we look at why we would choose ultrasound or CT, for example, well, it depends a lot on your availability. It depends on the sensitivity and the specificity of the different imaging modalities, whether your patient can tolerate the ionizing radiation dose. And in different parts of the world, this is probably more of a factor, is what is the relative cost of that imaging modality to the patient. So CT generally provides a greater sensitivity and specificity as compared to ultrasound. So we're looking at 95% sensitivity and 84% specificity, versus when we're looking at the ultrasound sensitivities and specificities, we're talking about upwards of 98% and 53% specificity. So these published values vary quite considerably. But another factor is the radiation dose. So, there is significant radiation dose depending on whether it's low dose CT or ordinary CT. So it can be ranged from 3 to 10 millisieverts versus 0 for an ultrasound. And the cost factor is significantly greater for a CT scan. You might also be considering what's the time that you need to wait for access to the CT versus the immediate availability of POCUS. And as I mentioned before, the patient's body mass index will impact the ability for that imaging modality to demonstrate what we need it to. So patients with a body mass index of over 30 are likely to image more poorly on ultrasound. In addition to all that, when we're ultrasounding, if those stones are stuck in the ureter, it can present a challenge for finding them because there's overlying bowel gas and increased depth of penetration to get to our target. And so it can increase the complexity of actually being able to see them. And it's only once it actually causes an obstruction that helps us highlight where they are. And even then, with that overlying bowel gas, it can be really quite tricky. Sometimes those stones, when they're smaller than sort of 3 to 5 millimeters, depending on which article you're reading, they're not big enough to produce a shadow. And so then it's really, really difficult to distinguish them from echogenic sinus fat. So I thought today would just quickly review the sonographic anatomy. We'd look at the scan technique. We'd look at the sonographic signatures of the renal calculi, and then briefly touch on some troubleshooting tips for how to get better imaging. So first of all, we'll look at the normal anatomy of the kidney and what we can see on the ultrasound. So you'll notice that the cortex of the kidney is hypoechoic. You get the anechoic pyramids, and it depends on your patient how anechoic they are. You have that central sinus area, which is quite echogenic on the ultrasound. So that sinus echo represents the renal vessels, the lymphatics, the pelvic calyceal system, which is not really seen so well unless your patient's fasted. And there's also fat in the sinus, which contributes to this overall white appearance. And if we look at this patient here in the longitudinal view, where the arrows indicate here, you can see the prominence of the renal pyramids. Now, sometimes you see that, but not in every single patient. The image on the right is a transverse view of the kidney at the hilum. And so you can see the vessels and the ureter sort of coming into the hilum here. What we do also need to do is compare the echogenicity of the renal cortex to that of the liver or spleen. And so, it's important to know what the liver characteristics look like. So we can see here, the liver here, we have the potential Morrison's pouch through the middle here, and then the echogenicity of the kidney, so the cortex of the kidney here, should be about equal or slightly hypoechoic to that of the liver. And because the spleen is the same sort of echotexture as the liver, you can use the spleen as a reference point on the other side as well. Now, sometimes you can get variance in the anatomy. So on this picture, we can see the extrarenal pelvis. And so this is a normal variant. Some people can just have sort of a bagginess of the pelvis here, not to be confused with hydronephrosis. And we know that this is sort of an extrarenal pelvis rather than hydronephrosis, because if it was hydronephrosis, you'd see pelvic seal involvement as well. Whereas this is just a dilatation of the ureter sitting outside the hilum of the kidney. In this example, we can see a column of Bertin. They represent an extension of the renal cortical tissue between the pyramids. And so they're normal structures, but sometimes these can be very easily mistaken for a solid mass or something. They usually become of radiographic importance when they're unusually enlarged. So we do need to be careful not to mistake them for a renal mass. And the way that I just double check this is to pop the colour on, and is the colour flow in that area normal and looking like what it does in normal cortex, or is it irregular and looking a bit unusual? So columns of Bertin are present in about 50% of the healthy population, and in 20% of people, they're bilateral. You can also see on some people a duplex collecting system. So it's the most common congenital abnormality or anomaly, should I say, of the urinary tract. In some cases, you have complete duplication, in which there's 2 collecting systems, 2 ureter and 2 urethral orifices. But sometimes it might be an incomplete duplication where there's just 2 collecting systems and the ureters join. Duplex kidneys tend to be a bit larger than normal as well. And what we do need to do then is look if there is hydronephrosis. Is it both the upper pole and lower pole equally involved, or does the presence of just dilatation at upper or lower end indicate that, you know, one of those moieties are dilated rather than the whole kidney system? So when we look at how to scan the kidneys, we look at the 3 Ps, and I do harp on about this a bit, but it's using the right probe to start with. In this case, the curvilinear probe is our best choice, making sure that we've chosen a kidney preset or an abdominal preset so that we optimize our imaging parameters, and looking at our patient positioning. So a lot of the time, particularly in the emergency room, the patients present in supine, and you can get reasonable imaging there. But if you roll them up onto their side, everything just moves slightly and into a very much better window so that we can get a better view of the kidneys. So remember to roll your patients onto their side, so left side down to examine the right kidney and vice versa for the other one. And, you know, that gives you the ability to access the kidney on the mid-axillary line or anteriorly, or coming in from the posterior aspect of the patient. When we scan the kidney, it's really important to make sure that we've covered from medial to lateral in that longitudinal imaging plane. And then right from the top of the kidney, from the superior pole to the inferior pole, to make sure that we have imaged the whole kidney. We should extend our scan past the boundaries of the kidney, because often you can have simple renal cysts that hang off the end. And so we want to make sure that we've seen the whole kidney and its relationship to the surrounding structures. Another important sort of technical point is to make sure that we are getting our scanning plane perpendicular to our target organ. So it's really easy to find some nice windows around the place and get visualization of the kidneys, but we do need to make an effort to bring our interrogating beam so that it's perpendicular to the kidney, so that we get the best reflection possible, and therefore the most nice image that we can, to be able to delineate these small structures. Particularly when you're looking for stones, you have to be perpendicular to those small stones to be able to get a good shadow from them. So make sure that you are moving your window and changing your probe position so that you can be perpendicular to your kidney. Now, when your patient's in the supine position, think about the FAST exam and how you'd scan the FAST exam. Bring your hand position down so that you get out of your own way and you can be able to perform a thorough examination. So come around and look as if you were looking for the right upper quadrant window. As I said, I have a very, very low threshold for rolling these patients on their side, because you do get better access. You can get an anterior window laterally from that mid-axillary line, and you can also scan posteriorly, all from that same sort of patient position. And so we need to fan in the longitudinal scan plane. We align our the longitudinal axis of our probe with the length of the kidney, which is often slightly oblique on the patient. And we need to scan from the medial to lateral portion. When we are scanning in transverse, again, you remember that the kidney is about 10 to 12 centimeters long, so you are going to have to move your probe. You may not get the whole kidney from just sitting in one stationary position. You need to slide the probe or sweep the probe over the length of the kidney to be able to visualize all the way from the upper pole to the inferior pole. And as you can see, as we sweep through here, at the upper pole, it will be a round shape where you can see the cortex of the kidney sort of making a circle. As you come through the middle portion, the cortex of the kidney will make that C shape around the hilum. And then at the lower pole, again, it will come down to make a round shape. Now, this sweep through in transverse is where you're going to properly sort out whether you have a duplex kidney or not, because as you sweep from the northernmost aspect of the kidney to the southernmost tip, you might see round, a C shape, round in the middle, another C shape where you've got the second hilum, and then round at the bottom. When we scan on the left side, we roll the patient the other way, and again, this gives us good access. Tricky thing here is that you don't have a liver which occupies as much space. So the left kidney is often a little bit higher in the abdomen and a little bit more challenging to get the nice pictures. So you do need to work with what you've got, figure out where your spleen is, either use that as the window or come around a little bit more posteriorly to get a nice window for the kidney. And then we need to, in the transverse, make sure that we are tilting and fanning the probe or moving our probe to get a good picture. Now, in amongst all this, it's always good to get your patient to take a really big breath in, because what that'll do is just push all the anatomy down a little bit out of the way of the ribs so that we can get a better view on the kidney. So often I'll just have a look before I get too carried away with imaging and just watch where the kidney is sitting and then emphasize, is it inspiration? Is it belly out? Is it expiration that gets me the best visualization on the kidney? And you exaggerate that and get your patient to hold that position. Then you just need to, as you've scanned, you document the scan in the two planes. So we get a longitudinal image, which is where we measure the length of the kidney, and then document in transverse to show that there's no dilatation that's involving the calyces, but also into the pelvis. So now let's look at those sonographic signatures. And the first one we'll look at is the renal calculi. Often these may be more obvious because if they're causing some obstruction, they get a little bit of water around them, which provides us with a nice window, but we don't always get so lucky. So we're looking for those stones that are bigger than 3 to 5 millimeters. If they're smaller than 3 to 5 millimeters, they're just not big enough for us to be able to generate a shadow. So the importance here is that when you do think you've found a stone, make sure that it casts a shadow in both the longitudinal and the transverse plane. And the reason for that is because sometimes the echogenic central sinus fat can sometimes cause a bit of a shadow, which may be mistaken for a big staghorn calculus or something. But the thing with that echogenic sinus fat that might cause a shadow in the transverse, you can't see it in the longitudinal view. So the thing that distinguishes sort of artifactual shadow from real shadow that is generated by a stone, the real stone shadow is there in both scanning planes. So you can see on this image, this really nice, bright, echogenic, white, very dense renal calculi, and behind it you get the acoustic shadow, and we also have another one here. Now, one of the important things for this is to make sure that your gain isn't set too high. I remember reading in an emergency medicine journal one time, they were talking about imaging renal calculi, but their gain was so bright that it just blended in so much and you couldn't see the distinction of the stone. So do tweak your gain settings a little bit so that it's not really, really bright and that you're, overwriting any shadowing from a potential stone. In this instant here, we have a stone that's causing a shadow here, and we also have a little bit of hydronephrosis, just some mild hydronephrosis. Here's another example, again, that echogenic calculi, and we can see the shadow here. You can use calipers to measure the size of the calculus. And as you can see on this one, it's a bit harder because that renal echogenic sinus is hyperechoic. This one, we can see the stone much more easily, only because of the fluid and the window that's being caused by that fluid in the renal pelvis there. Now, here's an example of something that mimics a stone. There are a lot of things that can be echogenic and white, and you think that they might be a stone, but this one here is the arrow there is pointing to the arcuate arteries in the kidneys, and so you get very bright reflector from those arcuate arteries. And it's not a stone because it's not shadowing. Now, is it a very small stone that is just not big enough to produce a shadow? We'd change our window here and slide to a slightly different position and see, can we still see that bright spot in the same place? There are limits to the size of the stone that can be detected on ultrasound. And so if you suspect that there are very small stones, CT is probably going to be more accurate in picking those ones up. One of the articles that I was reading said that you can overhydrate the patient so that you can cause a little bit of mild separation in the pelvis to help you highlight the position of the stone. I must say it's not something that I've ever done in clinical practice, but I guess that most of the time our patients are presenting well hydrated because we want them with a full bladder so we can examine the bladder and check for urinary retention and all that sort of stuff. So they're coming well hydrated, which increases the chances of seeing it anyway. So then if we look at hydronephrosis, you can see that there's a dilatation of the pelvic calyceal system, and it's usually because of an obstruction, whether that be because there's a stone in the ureter, whether that be because there's some sort of mass in the ureter or just extrinsic compression of the ureter. But you need to be careful that you have not got an over-distended bladder that is causing hydronephrosis. So typically when patients are examined in the imaging department, we ask them to come with a full bladder, and then we examine the bladder and we look at the bladder wall and make sure there's no nasties hiding there or any stones or thrombus or anything sitting in the bladder. We also use the full bladder to have a quick look at the uterus and the prostate. And then we measure the volume. We then get our patients to go to the bathroom and come back to look at their post-micturation volumes of the bladder and to demonstrate whether there is any urinary retention. Then we go up and look at the kidneys. And I guess my scanning technique has evolved like that because it's just one stop. You don't have to scan everything over and over again. So it's important to know, I think, before you go calling something hydronephrosis, you must have a look at the bladder to make sure that it's empty. And if the kidneys are still then dilated, then that's real hydronephrosis. But if you had some hydronephrosis and you had a really full distended bladder, then you have to be questioning, is that just backing up in the system because the patient just needs to go to the bathroom? So like I said, in my clinical practice, I've always just examined the bladder first, got the patient to pee, come back and then examine the kidneys so that we can determine whether it's true hydronephrosis or just separation because of over distension. Now there's degrees of hydronephrosis, and in the radiology reports, they kind of call it mild, moderate and severe, or mild, moderate and marked. And it depends on the degree of pelvic calyceal involvement, how you would describe this. So when we have mild hydronephrosis, you have an anechoic pelvis. You may see a little bit of separation and a little bit of hypoechogenicity in the calyces, but the calyces will be sharp and pointy in shape. And you'll also, if it's only mild, you'll also maintain the thickness of the renal cortex here. And so you can see on this one, it's only very mild, it's in the pelvis mostly. We're starting to get a bit of delineation of the calyces here, but it all forms sharp angles and is very square looking. When we have moderate hydronephrosis, you can start to see we've still got quite angular calyces, but it's a little bit more prominent through the pelvis here. And we also have the renal cortex maintaining its thickness. Whereas when there is severe hydronephrosis, if we look at the calyces now, they're quite rounded. And so you can see that they're under pressure here. And in this one, it's an example that's likely to be associated with long-standing chronic hydronephrosis, because you now cannot see any renal cortex here. It's all very thin, and there's not much renal cortex to speak of. So what we're looking for is rounding of these calyces, to call that. And I've heard this described in America as like the bear cub footprint. We don't get bears over here other than the odd drop bear or two, but it does look a little bit like a bear's paw print, I guess. So if we look at those side by side, this is on little kitty's kidney. You can see a little bit of separation through the pelvis here. It starts to involve the calyces, and you start to see the shape of the calyces. So we'd call that moderate. And then severe hydronephrosis, when you see it really distend, and we get thin renal cortex here and rounding and clubbing of those calyces.
Suean, can I ask a quick question?
Yeah.
In my experience in the emergency department, the dichotomous question we're asking is yes, no hydronephrosis. And with kidney stones, honestly, it seems like 85 to 90% of the times, the hydronephrosis that is present is mild and actually rather subtle. Do you have any tips or tricks on how to differentiate or pick up that mild hydronephrosis? So often there's vessels around and everything else.
I would turn into a short axis view and put the color on, and you'd be able to see what's vessel and what's not. The renal, at the pelvis, the renal vessels, the renal artery and vein is really quite easy to determine on the color Doppler. But I guess it's just it's a pattern recognition thing. If you could practice on your pregnant patients in the first trimester. If they're about 10 to 12 weeks, they're going to have mild hydronephrosis of the right kidney pretty much most of the time, just because where the baby is sitting, it's starting to obstruct the pelvis, obstruct the ureter. So, if it's mild like that and they've gone to the toilet, that's not as much a big concern, I think, as if you look and it's looking like this marked version or something more. See the separation here where there's no question when it's like this. This is like, oh, yeah, maybe not. You're wondering. I guess that's not as important. It's when we're starting to get to here or this clubbing where things are starting to get more worrisome. But you could practice on your early pregnant patients because their right kidney in particular is often mildly dilated, the left kidney not so much. Now, the hydronephrosis, well, not so easy as you say, but the pelvic calyces, or the calyceals, if they're really rounded, they can look like renal cysts, but a simple renal cyst is something that is really quite common just in the general population. It's a bit like thyroid cyst. If you scan a couple of kidneys and thyroid, you're going to find a cyst somewhere. So a simple renal cyst is defined because it is round, it's smooth walled, and it has good through transmission, and it should be anechoic in the cyst. So you can see here, it's very round, very smooth. There's good through transmission or posterior enhancement, and all you need to do is measure those. It's really, really important to make sure that you scan through all the way to the lateral edge and medial boundaries and all the way from north to south pole of the kidney, because they can often just hang off the end. Here's another one at the lower pole of the kidney. And you can see that we've got some edge artifact here, but the posterior through enhancement here is really quite prominent. It's the parapelvic cysts that are really quite difficult to figure out. Is that hydronephrosis or is that parapelvic cysts? Now the report says parapelvic cysts. I'm going to believe that they're parapelvic cysts, but these cysts look a little bit square as well. So it's really quite tricky to figure out, is that the parapelvic cyst or is that the actual pelvis and pelvic calyceal dilatation? And I guess the trick here is to make sure as you scan through, are you seeing an edge to the cyst or is it continuous with the pelvis and down to the ureter?
Would they usually be bilateral also?
Well, it depends with hydronephrosis because it could be just a stone on one side, but they might have some cysts on the other side as well. So in my experience, having parapelvic cysts like this one, they're probably going to have a cyst somewhere as well. But this one's tricky because it's not in the cortex so much as well. And so here we've got an example of pelvic calyceal dilatation, and you can see how that is continuous through here and connects up to that ureter or the pelvis, whereas these are quite finite. And as you can only sort of tell that in real time versus on this still image that I have here. As you scan through, if it's pelvic calyceal dilatation, those pyramids join up to the pelvis, whereas in the parapelvic cysts, they are defined and you can see the edge of them. And we'll get lastly to some troubleshooting. I think the biggest tips that I can pass on to you is to make sure you roll the patient on this side, make sure you emphasize the breath in, or, for some patients, the patients who have like the solid beer belly, and they're quite, when you roll them on their side, they're quite square almost. They have really nice images of the kidneys because they have lovely perinephric fat around them. But sometimes you need to ask those people to push their tummy out. So it depends on their body habitus, depends on how well they can breathe in and stuff. But exaggerate breath in, sometimes try a breath out, scan from the anterior, the mid-axillary line and posteriorly to see where you're getting the best window. Be perpendicular to your kidney to get the best reflection, particularly if renal calculi is your suspected diagnosis, and make sure you do scan through the entire kidney. Don't just plonk the probe on and get stuck in the middle of the kidney. You need to make sure you go from the medial to lateral margins and from inferior to superior on the kidney. Does anyone have any questions there?
Suean, I've had questions. Brian Doyle, emergency physician from Hobart. Hey, thanks so much for that. I appreciate the tips about rolling the patient. I think a lot of emergency doctors are a bit lazy about the patient just being supine because we're so used to the fast exam. So I really appreciate you giving us that tip, and I'll continue to try that. Generally, as I said before, the dichotomous question we have is yes, no hydronephrosis, but you had talked about, well, being able to actually see the stone. The most common place where the stone will usually lodge is the UVJ, the ureterovesicular junction, and you get a clue on history because they got pain towards the front in the inguinal region. I've tried to pick up the stone at the UVJ, sometimes looking for a little bit of a twinkle artifact at the UVJ. I'm not sure if that's something you've tried or taught, or I'm often frustrated by it, to be honest with you. But what are your thoughts?
I'm frustrated by it. I know that, look, there was some years ago, they used to go on about this twinkle artifact. I personally, look, some people might have a different experience of this, but personally, every time I've done it, I've either, it's everything twinkles or nothing twinkles as much as I think it should twinkle. So I've often been really frustrated by it and don't rely on it. But other people might have different experience. I know there's some sonographers who absolutely swear by it, but it's not one of my favorite diagnostic criteria personally.
What about ureteric jets? Do they help you?
So I think the ureteric jets, we covered ureteric jets and how to scan those in an earlier edition of the coaching corner. So if anyone wants to look through them, I think they're in one of the first or second, about this time last year now. I think the ureteric jets is something that you need to be doing that each and every time to build your confidence that you're actually going to see them and that you know how to optimize your imaging parameters so that you can see them. If you've got someone who's in some sort of acute or even chronic renal failure, you're going to get no renal jets. I think visualization of the jets tells me that there's urine coming through. So yes, that's good. And it can tell me, okay, that one looks fine. But if I don't see it, I can't use that to rule out a stone, because it might be that there's intermittent obstruction. It might be that you haven't got your scanning parameters set properly so that you can actually visualize the jets. You can't, in my opinion, you can't just come along on that case where you think there's a stone and you're not quite sure, and just on that occasion only turn on the jets and hope that they're going to help you out, because it's just not going to work unless you've actually developed the technique and are used to optimizing your machine so that you can see the color jets from the passage of urine. So yeah, it can say, okay, that one's not obstructed, but if you don't see it, there could be other explanations like renal failure or intermittent obstruction.
Fair enough. I think the biggest challenge or barrier we have is time. I don't think any emergency physician wants to wait a minute or two.
Well, and I
conversation.
think if I remember rightly, I think there's supposed to be 1 or 2 jets every 150 seconds or something, and everything from 150 up to 300 seconds or something, vaguely from my memory. Sitting there for 3 minutes is a long time. So yeah, in the emergency room, I don't know that it's the most practical of scanning tips that you can do to rule this in or out. Hello, Rajesh. I've seen a couple of extra faces have joined us as we've been talking.
Hi, Suean.
How are you?
Good, thanks. How are you?
Good. Are there any other questions, comments from anybody?
Just a quick comment about, you mentioned about commenting on hydronephrosis, not until you scan the bladder. Is that
Yes.
actually, because there's a lot of variation I've noticed in the sonographers themselves, like they just start with the kidneys because that's what they focused on, and then they move on and, hey, go to the bathroom, come back, bladder, that's it.
Yeah, I guess, look, I don't know that there's necessarily an absolute right or a wrong here. The way that I do it, where I do bladder first and then the kidneys, is for a couple of different reasons. One, if there is hydronephrosis and then I have to repeat the scan of the kidneys again after they've done their bladder, it's extending my scan time. And the other reason is, for most patients, we've asked them to fill up and they're busting to go to the toilet when they arrive. So I want to get that out of the road to get them comfortable so that then we can go on and take our time with the kidneys and do the bladder volumes. So it's not so much that there's necessarily an absolute right or a wrong. I guess my practice has evolved out of a concern for making the patient comfortable and for not wanting to double do the kidneys, so that I can just save time, because we're always pushed for time.
But it does make sense. I mean, the fact that what you mentioned, it does make sense, like physiologically. So thanks.
Yeah. Look, and the other thing too, you know, with a full bladder, if we're in imaging circles, if we're scanning a male patient, you've got to measure the prostate and all the rest of it. So that takes a little bit of time. And I don't want to be kind of stuck doing all that at the end of the scan when they're seriously busting and they're jigging on the table and they start to get a bit short with you. So yeah, there's a couple of reasons why I do it that way. And it solves the problem of the patient comfort, but also just this physiological hydronephrosis problem.
I do recall a case, having said that, I had a case around midnight, someone who came in a bit like older sort of age group, came with acute retention, but acute in the sense it was going on for a day.
Yeah.
But he didn't just present on time. And I noted, we did put a catheter. I noticed massive gross hydronephrosis, and I was more skeptic about the hydronephrosis. I said, okay, well, I'll keep him overnight to get a formal scan. And I chased the formal scan, and it turned out to be normal because he was just distended from his retention. So that proves your point.
Absolutely. And like I said, a good way to practice the mild hydronephrosis versus, you know, physiological is scan your early pregnant patients' kidneys. And it's typically, you know, about 10 to 12 weeks. By the time the uterus is that big, it starts to push on things. And I've noticed, just coincidentally, I don't know if there's papers written about it, but just anecdotally, the right kidney is always a little bit sort of distended and mildly hydronephrosis, and the left kidney will be more normal looking. So that starts to help you get your eye in for sort of mild cases, because then if you're scanning someone who's not pregnant or who is unable to be pregnant because they've got the wrong equipment, then you start to get practice at being able to identify that.
Just a quick question on regarding the pregnant patients. Is it something? Is there a correlation between pyelonephritis and early pregnancy? There's some kind of more preponderance in those ones. Like, I've heard about that. Is there something like haven't heard anything like that?
I couldn't comment on that. No. Does anyone else have any info on that?
Yeah, I haven't heard about that either, but I would imagine that urinary stasis would be a risk factor for potential developing upper urinary tract disease.
Yeah.
Yep.
Lynn was just saying sometimes it can take quite a few minutes for that mild hydronephrosis to resolve after they're voiding. And she does have a point, you know, if they dilly-dally a bit in the toilet and come back, it can take a little bit for that to, for some patients, for that to sort of resolve. But it would certainly explain, Raj, your patient who was quite hydronephrotic one day and then they had their formal scan and they weren't, because they've probably emptied their bladder and it's all gone. Well, excellent. Has anyone else got any other questions? I might then just wrap up with a quick summary of what we've covered here. So we did a quick whirlwind tour of the anatomy. We've given you some tips and tricks for scan technique. We've looked at the sonographic signatures, in particular of renal calculi, hydronephrosis, and some simple cysts. And we've also sort of briefly touched on some troubleshooting techniques so that you can improve your imaging. And I'm going to just point out again, I think the biggest mistake that can be made in the emergency room in particular is the gain setting. So make sure that you have a look at the echogenicity of the kidney against the liver. Is the liver look really bright white? Well, you've probably got everything a little bit too high. So just make sure you've got nice, even grey gain settings across the whole field and not too bright. And with that, I'd just like to once again just acknowledge our sponsors. Philips has proudly sponsored tonight's coaching corner, and we do thank them for their support.